and welcome to the Weekly with Dr. Tom. This is your way to stay up to date with everything healthcare related across the country. This week, we'll be joined by Dr. David Albiani, a UBC retinal specialist. We will review the importance of blood sugar, blood pressure, and regular eye screening for eye health. We'll also explore the types of treatment available for diabetic eye disease. There will be a Q&A session at the end of the seminar. Submit your questions throughout by using the Q&A button at the bottom of your screen. Dr. Elliot will answer as many as possible live, but all will be answered by case managers in writing. We look forward to your engagement. Now, here's Dr. Tom.
Good afternoon, viewers, and welcome to the 10th edition of the Weekly. Today, we continue with our focus on individual body organs and how best to preserve and protect them while living with diabetes. This week, we move to our eyes, indisputably precious and vulnerable, and our primary contact with the outside world. We are greatly privileged to have Dr. David Albiani, UBC retinal specialist, as our guest and content expert today. But before formally introducing Dr. Albiani, who I know is going to be telling us about what he does when I send him our high-risk patients, I wanted to review with you what you and BC Diabetes team can do to prevent eye disease and how we are doing on that front. So this is just a reminder that sugar is all important. We want your A1C under 7, and ideally you're using a continuous glucose meter, in which case we want your time in range greater than 70%. We want your blood pressure less than 140 for sure, and ideally lower if you've got eye disease. We want you to be on a cholesterol pill. Ideally, your LDL or bad cholesterol will be less than 2, or your ApoB, the preferred test at BC Diabetes, will be less than 0.8. And then we need to make sure that you get your eyes screened so that if there's a problem, we can send you to Dr. Albiani. Next slide, please, Luke. Well, our policy at BC Diabetes that every person living with diabetes gets a screening exam every 12 months. And here are the numbers that we got from our database query done yesterday by our systems administrator, Sergey Skopkarev. Sergey, thank you very much for this quick work. At the time of the last visit, the median patient, in other words, people in the middle of the distribution at BC Diabetes had their eyes screened within the last 9 months. If we look at the average visit, this includes all the compliant patients as well as the non-compliant patients. The average person has been screened within 15 months. 24 months is the outside recommendation for screening, and I'm happy to say that 70% of people seen at BC Diabetes have had a screening visit in the prior 2 years. What about those people who haven't met that 24-month or 2-year condition? Well, I'm happy to say that once we've seen them and given them our talk, that they get their eyes checked, but it takes another 14 months before that happens. Next slide, please, Luke. Well, what happens when we send our patients for a retinal screening? This is either done by an optometrist or an ophthalmologist. Happily, 76% of patients have a normal retinal exam, meaning there is no problem whatsoever. But 24% have a problem. Less than 1%, I'm pleased to say, have advanced visual loss. So Dr. Albiani comes in when we consider the patients, the 24% of patients who have abnormal testing. Now, looking at the BC Diabetes data, patients who've been referred to a retinal specialist like Dr. Albiani, of them, 8% of BC Diabetes patients have had laser therapy alone. Another 2% of patients have had the latest therapy that I know he's going to tell us about, anti-VEGF therapy. And another 2% have had a combination of laser and anti-VEGF therapy. Now to our guest. Dr. Albiani is one of our local superstar diabetic eye specialists. He's a Sudbury, Ontario native, went to medical school at Queen's, did his ophthalmology residency in Ottawa, and then in 2008, when I first met him, came to UBC for advanced fellowship training in the diabetic retina. He's been in Vancouver ever since and is on staff at West Coast Retinal Consultants, which has an office on Broadway in Richmond and another in Surrey. He loves his work and told me how he's been quite frustrated by coronavirus, not being able to go to work. You can count your lucky stars, David. We've been working absolutely flat out doing virtual care, and that's what this webinar is about. David is deeply involved in medical administration, head of the Division of Ophthalmology and of Medical Affairs at Providence Health Authority. David, welcome to the Weekly.
Thanks very much for having me, Tom. And you know, it's wonderful to be here and to be able to talk about the eye. It was something I'm very passionate about. As I told you yesterday, you know, we could talk about this for 5 minutes, or we could talk about for 5 hours. But it's great to be here, and I'd like to kind of get into the meat of it. I just a comment about your database poll that you did. That's very impressive, frankly, that you have such a high screening rate, and it's a testament, I think, to your system and your organization. You know, that's far better than most published literature on the screening rate for patients with diabetes for their eye screenings. And so that shows you're doing a good job. And in addition, because the screening rate is so high, you're able to catch diabetic retinopathy earlier and probably have a lower intervention rate and better visual outcomes. So that's you know, that congratulations on doing such a good job with the screening and management of your patients. So I decided that we should talk a little bit about diabetic retinopathy. So it's a very common problem with patients that have diabetes, especially if you have moderate to poor control of your serum glucose, and if you've had diabetes for a long time. So let's just go to the next slide. And so diabetic retinopathy in North America is the most common cause of blindness in working age patients. And the risk factors for developing retinopathy and for getting vision loss are how long you've had diabetes, the diagnosis, what your level of serum glucose control. And there's good evidence that you know, having hypertension or hyperlipidemia also gives you a higher risk of having vision loss or diabetic retinopathy. And so some of the first symptoms from diabetic retinopathy would be some distortion, or the medical term is metamorphopsia, or reduced vision. And you know, also more advanced, you can get sudden spots in your vision and sudden visual loss if there's a bleed in the back of your eye. Next slide, please. Very good. And so, Tom, you went through some of the screening and referral guides, but for type 1 diabetics, you typically do get a screen right on diagnosis, but realistically, patients don't develop retinopathy for typically at least 5 years after being diagnosed. And interestingly, being a child tends to be protective from developing diabetic retinopathy, so you don't tend to get it until after puberty. With a type 2 diabetic, we know that we're not sure when they actually develop diabetes, so we tend to screen every 1 to 2 years after diagnosis. Now, 2 years, if you have no retinopathy, there's good evidence that you can screen the patient every 2 years. But we know that when we do that, we sometimes lose patients. So sometimes we'll see people annually even though they have no retinopathy. And then we'll see people more frequently if they have moderate to severe diabetic retinopathy, and if they have other problems with their eyes like cataracts or glaucoma. So next slide, please. So this is a key slide. Diabetic retinopathy is a disease of your capillaries, and a few key changes happen in the capillaries that drive all the changes that we see in diabetic retinopathy. So some of the cells that line those capillaries get lost because the high serum glucose, and you also get thickening of the little membrane on the surface, and that causes a bunch of downstream effects. Next slide, please. And so what happens is you get blood vessel permeability, so you get swelling and fluid leakage and blood leakage from the capillaries, and also you get closure of those small blood vessels that leads to new blood vessel growth, and these new blood vessels are friable and fragile, and they can break open and bleed very easily. Okay. Next slide. And so we get the main cause of vision loss are swelling in the center part of the retina, so diabetic macular edema. And also when you lose the capillary flow to your retina, you get little blind patches that you can't see through. Those can subsequently develop into some bleeding in the vitreous jelly, so that's why you would see spots floating in your eye. And then more rarely, you can get blood vessels growing on the front part of your eye, and they can block off the drainage system. Okay, next slide, please. And so we classify diabetes into non-proliferative and proliferative. And so non-proliferative means that there's no new blood vessels growing, but we see little bruises or hemorrhages in the back of the eye and the retina, and little fat deposits that we call hard exudates, and sometimes little microinfarcts or little blood vessel spots that don't have good blood flow, and they look white to us. Later on, you can get new blood vessel growth. We call that proliferative, and that causes some of the more advanced changes in the eye. Next slide. And so this is a picture. This is what I see when I'm in my clinic every day. On the left, you'll see an OCT, or optical coherence tomography, and basically this is like an ultrasound using light energy that shows us very, very finely how thickened the retina is or is not. And so in this photo, up on the left, you'll see a photo of the central macula, and up on top, there's a few little dots of fat deposit in the retina, and over on the side, a little spot of blood. But when we look at this OCT, there's no swelling of the retina. So someone that has this will have diabetic retinopathy, but really will have just a little bit of distortion in the bottom part of their central vision. But they're seeing quite well, and they may or may not need treatment at this point. Next slide. And so, just one back, please. And so and we'll compare that to this other patient who has a little bit of swelling right at the center, and also some fat deposits at the center. So that will cause quite a bit of disturbance in the vision, and this patient should get therapy to control the swelling and the leakage of the fat right in the center. And we can repeat these scans every time someone comes in to see us, and we can see in time what their central macula thickening is and how they're doing. And you see down on the bottom, a little topographical map of where the thickening is. So red being a little thickened and white being very thickened, and we don't want thickening, obviously. Next slide. And so as we move along, you can get new blood vessels growing if there's poor blood flow in the back of the eye. And this is a photo of some new blood vessels by the optic nerve up on the top right of your screen. And this patient's already had some therapy, so there's some laser over on the left side. Next slide. And so when we see this kind of patient, we'll often do something called a Fluorescein angiogram. And so this is an angiogram where the dye comes out as white for us, and we see leaking from those new blood vessels. And then over on the left side, there's really no good capillary flow, and the patient's been treated with some laser in that area to selectively kill off the retina and stop the drive of new blood vessel growth. Next slide. This is actually the wide field view of that same patient. Okay, so the retina is, we're talking about the macula is the very center, 4 millimeters, but the retina is a very big space, and all those retinal cells that aren't getting good blood flow are driving new blood vessel growth in diabetic retinopathy. Next slide. And so this is a slide where you see new blood vessels growing on the iris. And this is a very dangerous situation where you can get a blind, painful eye. And so this is what we really want to avoid. So that the blood vessels grow on the iris, and then they block off the drainage system, and the pressure can go up very dramatically and very quickly, and then cause you to have a total loss of vision. Next slide, please. And so, the first part of diabetic retinopathy management is all the stuff that patients do with their endocrinologist and family physician. And probably that's the most important part is to avoid having diabetic retinopathy or severe diabetic retinopathy in the first place. And that's serum glucose, hypertension, and cholesterol, regularly coming to see the eye doctor when they're asked to. And when we do that, we have really good outcomes. But if you do develop diabetic retinopathy that requires treatment, we have a full armamentarium of very good therapies that can help patients. And so when you have swelling in the center, so that the more common reason for vision loss, we can inject these anti-VEGF agents that shut down the process where new blood vessels are growing or swelling is happening. And we can also use steroids to do the same thing. We can also use some focal laser. That's a more historic therapy that we use sometimes that basically cauterizes those little blood vessels that are leaking right near the center. As we get into more advanced disease with new blood vessels growing and bleeding inside the back, we can use those same drugs to do that, the anti-VEGF agents, and we can also use that heavy laser called pan-retinal photocoagulation that we saw in that one angiogram patient. As if there's so much blood in the eye that we can't see to do the laser, sometimes I'll do surgery where I go in and I take the blood vessels and all the vitreous jelly out, and that actually helps oxygenate the retina because the vitreous is an oxygen sink and sucks up oxygen. And so that patients can have a very nice outcome even when we get to that stage. Next slide. And so I did want to show this one slide about therapy. And so, you know, when patients hear that they might get an injection in the eye, it's a very daunting realization. But I can assure you that we do lots of these. I think my partners and I each average about 6,000 of these injections a year, and it's a very fast procedure and relatively painless. Sometimes it's a quick pinch, sometimes no pain at all. But this is just a photo of where the injection goes. It goes about 4 millimeters from where the white part of the eye meets the cornea. And below the photo of the injection is what you can expect. And so we measure vision in lines of vision. And so there have been, you know, many studies published on many of these anti-VEGF agents. And the line on the bottom is patients without treatment. They tend to have relatively stable or reducing vision. And the patients that get these injections tend to get, you know, about 3 lines of vision improvement once we start them. And they tend to keep that vision. And so it's very effective. Our historic therapies with the laser only just stabilize vision. They didn't get this big bump in vision. And that's why these anti-VEGF agents have become so popular and so effective. So there are very few interventions in ophthalmology that give you this kind of wonderful outcome for patients' vision. The only other one would be cataract surgery, really. Next slide. And so there are issues, of course, doing these injections every month, and different strategies have been employed. There are different molecules that we can use for these anti-VEGF injections. The other thing is that we can use steroids, which last a little bit longer, or laser. And it's not a one-size-fits-all approach. You have to take individual patients, their social circumstances, how far away they live from the clinic, for example, and take those all into account to get an individualized or personalized treatment algorithm for patients. The other thing is, too, the anti-VEGF agents were initially used for macular degeneration. So these are patients typically in their 80s. But because people with diabetic retinopathy tend to be younger, they tend to be on them longer. And so these are long-term therapies for people. And of course, you know, your sugar control, hypertension control are important, but we don't see that, we don't derive the benefit from those interventions usually for several years. So we have to use these medications in the interim. Next slide. So that's all I had. I hope that was useful for everyone. And if you have any questions, I'm happy to go through things with you.
Thanks, Dr. Albiani. Yes, we're going to go to a couple of questions now. We're going to lead off with Marge. She asks, can medications like Ozempic cause eye problems?
There are a few of the anti-hyperglycemics that can cause some macular edema. I'm not familiar with all of them that can cause them, But that's one of the concerns, is that some of the diabetes medications can cause swelling. And so we have to tease that out. So we do ask patients which medications they're on, and if we think that the diabetic medication is exacerbating or causing the diabetic macular edema, we may ask for a switch.
It's very helpful. Our next question is from Michael. He says, Dr. Albiani, I've worn glasses and contacts for nearly 30 years, and I've had type 1 diabetes for about 10. I've been hesitating about laser surgery to correct my eyes. I worry about having complications with sugars during the procedure and becoming one of those with a negative outcome. Any advice?
Well, there's a couple of things there. So patients that have diabetes do tend to have a slightly more loose epithelium on their cornea and a slightly longer healing time for the epithelium. So some of the refractive surgery procedures, they'll take the epithelium off your cornea, and then they laser, and then they either put that little epithelium back or they just let it regrow over. And so you're right, there's a little bit of a higher risk of a complication from that. But even with that, I think most people that have diabetes and go for refractive surgery still have excellent outcomes. And I don't really think it's a reason not to have refractive surgery. So that's the kind of corneal refractive surgery piece. There's also patients with diabetes tend to get cataracts earlier in life, okay? But again, they tend to get through those surgeries with very well and have excellent outcomes. And so I don't think having diabetes is a reason not to undergo eye surgery. I think you should, consider what you want and what your outcomes, what your desired outcomes are, and go from there.
I'm sure he'll find that. I'm sure that'll bring a lot of ease and comfort to him. Now, Dr. Elliot, Michael asks what your thoughts on these procedures are.
Well, I'm going to talk about. I'm going to leave this to Dr. Albiani. You know, why do we have experts in life? We have them so that we can rely on them. And it's one of the wonderful things about doing the weekly that I can ask an expert to come in to make my life easier, but not just that, to give you the bottom line. So I'm not going to say anything further about that, but I do want to talk about the importance of screening. And, you know, it's a deadly serious thing that we recommend. And it's frustrating when our patients don't go for screening because we know that they're more likely to have a worse outcome. Dr. Albiani, I have a question for you. If a patient comes to you, has problems, but still has reasonable vision, if you do everything, if they agree to everything you recommend, is that a guarantee that, that they're going to keep their vision? Can you comment on?
So no, so it's not a guarantee that they'll keep their vision. But as you saw from my list of potential therapies, if they do kind of follow our treatment regimen, most people will do very, very well. And so in particular, so the different problems, so if you have diabetic macular edema and you get at it early, so the macula, think of it as the most complex part of your brain where all the cells are tightly packed, but they're very delicate. And when you have them swollen and have little bits of blood and fat in there, it damages some of the cells. The longer you leave it, the more low-grade damage that you're going to have. So if you have just a little bit of swelling and we give you one of these injections and it goes away within a week, there's almost no damage to your vision and no long-term sequelae. But if you leave it like that for a year and don't treat it, then, even when I get the anatomy to look really nice on the picture, patients won't necessarily see much better. And so you got to think of your retina as a part of your brain and with a limited ability to heal. But if you keep it in that anatomy, you'll be in good shape. The other thing is, though, if you get relatively rarely someone, especially with type 1 diabetes, will get that capillary poor blood flow right at the center. And so if you've lost vision from poor blood flow, you got to think of it a little bit like a stroke. We don't have good treatments for that. So we have good treatments for the swelling. We have good treatments for bleeding in the center part of the eye. We can totally fix that. But if you have poor blood flow and you've lost some of those nerve cells, then we don't have good therapy for that, and we can't get a good outcome sometimes visually.
Wonderful. We're gonna have one more question here. This one's from Donald. He asks, does retinopathy cause color confusion? I have blue/green color confusion, or is it caused by the argon scatter laser or cataract growth?
Yeah. So there's there's several questions there. And so first, you know, some people, especially males, can be red-green colorblind. So that's a very common thing. The argon laser that we use is usually used over on the side and doesn't affect color vision at all. Except for the first 20 minutes after you've had the laser. If you have an asymmetric cataract, so let's say you had a really dense cataract that's blocking a lot of the blue light in one eye, and you'd had almost no cataract in the other eye, you might have disparity and so typically those people will see very little blue in the cataract eye, and they'll see the blues better in the other eye, and that could cause some confusion. And interestingly, when you have someone who has a cataract surgery, they'll often tell you, "Wow, I haven't seen blue in several years," you know, and they'll be just thrilled.
Lovely. Thank you, Dr. Albiani. At this point, we're going to go over to Dr. Bobby Sidhu, who's a BC Diabetes case manager and physician assistant. Bobby?
Hi, thanks, Tristan. So hi, everyone. My name is Dr. Bobby Sidhu. I'm one of the diabetes case managers here, and just one part of your diabetes care team here at BC Diabetes. I've been working with Dr. Elliot and the team here since 2016. And my background is primarily in family practice with a special interest in training in mental health and managing the distress that we all experience from time to time. Now, one of the things I want to mention is, you know, during this COVID-19 pandemic, we are in, you know, a very unique situation. One thing I've learned is I think we all need to take a little bit more time and effort to take care of one another. And I don't just mean your friends and family. I would love for all of us to just take care of each other as, you know, as humans, as Canadians. And, you know, the whole purpose of, you know, someone like me here is to make sure that we impart the clinical pearls or the knowledge to help you all be successful as our patients here. We all want everyone to do well. And the key piece for me today is a quick little pearl is the most powerful and effective therapy that we can all do is switching to a low carb diet. And a low carb diet is actually fairly easy to do, you know, in terms of making small adjustments at a time. And a very simple way to understand what you want to do is switching or cutting out, eliminate white colored foods. And generally speaking, we're talking about sugar, added sugar, so white sugar, brown sugar, or honey. If you need a sweetener, you know, artificial sweeteners are okay, Splenda and stevia. If you do consume foods made from white flour, like white bread or pasta, maybe switching to a whole grain variety. White rice is something that's common in a lot of diets. I mean, basmati is the best variety of rice, but switching to brown is better. And obviously our beloved potato, we all love you know, the white potatoes, fries, etc., mashed potatoes. Who doesn't like mashed potatoes? But switching to sweet potatoes or yams is a better option. But ultimately, these are all starches. So if we can lower the portion of these foods, what can we switch to? Vegetables that grow above ground. Very simple way to remember. If it grows above ground, it's probably a good vegetable, and obviously consuming lean proteins. There, back to you, Tristan. Thanks.
Thanks, Dr. Sidhu. That was wonderful. We have a couple more questions. This one's from Barry. Dr. Albiani, are all the offices open for the yearly checkups right now? I've been holding off because of COVID. Thanks.
Yeah, that's a very pertinent question. And so the retina specialist offices throughout BC are pretty much all open. So we deal with not just diabetic retinopathy, but patients that have retinal detachments, and other emergency conditions. So I've worked through the pandemic. That being said, patients that are on an annual visit schedule, we've been calling those patients rather than seeing them in the office and trying to defer their in-office visit if we can until after we think the danger from COVID is lower. We've also changed but some of the patients that have been getting active injections have been coming in to our office, but we've changed the patient flow in the office. You know, you can see I'm working today actually, so we're all wearing personal protective equipment in the office, all the staff, and patients are all wearing masks in the clinic, for example. So it is a totally different setup, but we are taking care of patients during the pandemic. Of course, trying to avoid the visit if there's no good reason to come in urgently.
Wonderful. This next question is from Jonathan, and it's to Dr. Elliot. For regular eye examination for type 2 diabetic patients, would we go to an optometrist or an ophthalmologist?
Thanks for the question, Jonathan. I think the key piece is that you go to someone who's competent. So we do have some local optometrists who are very competent in diabetic retinal screening, and we use those. The safest thing really is to seek the advice of your physician. So we will give a recommendation if you're seeing us, otherwise see your family physician. That's the bottom line is competence.
Okay. The next question is for Dr. Albiani. Are microaneurysms in the eye completely different than the swelling? Would they be considered early bleeding? Could you elaborate on this?
Certainly, and so microaneurysms are one of the earliest changes from diabetic retinopathy. So when I put up that picture of the capillary, there are small little dilatations of that capillary that look exactly like a little hemorrhage when we look at them directly. Now you differentiate a microaneurysm from a micro hemorrhage using the angiogram. So on an angiogram, the aneurysm will light up like a Christmas tree, and the hemorrhage will block or be dark because it's just a collection of blood. And so what happens is those little aneurysms, when they leak, they cause the edema or swelling. So they're not the same thing, but it's kind of like the aneurysm causes the swelling. So it's kind of all part of the same process, but a little bit of a different thing.
Okay, we have one more from Donald. Is ptosis related to diabetes or natural aging?
So most ptosis is due to natural aging. And so what happens is typically your upper eyelid has a series of small little ligamentous connections from your upper lid muscles into a little piece of cartilage called the tarsal plate. And so as we get older, and if your eyelid's been stretched many times, you can lose some of those connections and the eyelid tends to fall. Now one reason to get ptosis that's associated with diabetes is if you get a third nerve palsy. So sometimes people with diabetes will get a small little microinfarct of their peripheral nerve, and then their eyelid will get droopy all of a sudden, and they'll be looking down and out. And so if that happens, it typically recovers all on its own, but it's associated with diabetes actually. Yeah.
Okay, we have one last question here. It's from Barbara. If you have already had laser surgery on your eyes twice in 8 years before a type 2 diabetes diagnosis, does this increase your likelihood for eye issues in the future, Dr. Albiani?
So in ophthalmology, there are many different types of lasers. So I assume that the question is about having laser refractive surgery, not laser for your diabetes. And so if that's the case, really the laser refractive surgery doesn't impact your risk of having problems in the back of your eye. They're very independent. It does make it a little bit more difficult to select a lens that you need when you get cataract surgery if you've had previous laser surgery. So you want to keep your records for that reason and potentially go to the same ophthalmologist that did your laser surgery initially.
Okay, thank you, Dr. Albiani. At this point, we're going to go to Dr. Elliot, who's going to introduce Arthur's Corner and the concept and what it's going to be about. Dr. Elliot, please.
Thanks, Tristan. You know, it's our 10th weekly and we're maturing, we're getting a bit more relaxed. I'm realizing I need to use not just need to use, but I have a fantastic team. And so I want to introduce them to you. You've already met Dr. Sidhu. We'll have a case manager on each week. We also have a staff scientist, Arthur Weisinger. Arthur is an emeritus professor at North Carolina State in molecular biology. And he keeps us honest at BC Diabetes. He keeps us on track. He writes our protocols. He organizes journal club. And we're going to have a little 1 minute or so with Arthur to tell us something important about contemporary science. Dr. Weisinger, what are you going to tell us today?
Today I'm going to talk about herd immunity. You may have read about herd immunity and how it could make us all safe from COVID-19 if we just let ourselves be exposed to the virus. This sounds good, but let's take a look momentarily at just what it really means. Herd immunity occurs when a large part of a population becomes immune to a disease either through natural infection or vaccination. The population is then protected by the fact that there aren't as many susceptible people available to spread the disease. To achieve herd immunity, a certain proportion of the population has to become immune. And although we don't yet have enough data to be sure, our best estimate is that to achieve herd immunity against this virus, as much as 74% of the population needs to be immune. For Vancouver, that's about 500,000 people. As of yesterday, there were only 2,550 cases in all of British Columbia. That means that to achieve herd immunity through natural infection, a lot more people would have to get sick, and unfortunately, a lot of people would probably die. The truth is, we're still a long way from herd immunity. We probably won't achieve it until we have a vaccine. So for now, our best defense against COVID-19 is to continue wearing our masks and maintaining our social distancing to avoid infection.
Thanks, Arthur. I'm already looking forward to hearing from you again next week. Back to the Q&A. It's for Dr. Elliot. What sort of extra precaution or measures should someone who's been a diabetic since the age of 16 take to avoid any need of medical treatment?
Well, that's a wonderful question. So let's start with sugar. I want you to have optimal blood sugar or glycemic control. The blood test, the A1C that we recommend every 3 months, reassures us as doctors that you're on track. But what you need to do is to measure your sugar at home somehow. We love the new technology embodied in continuous glucose monitors, and we can't wait for the province to cover them. Minister Dix, if you're listening, number one on my wish list for you is to cover CGM. So ideally you'd have a CGM at home. If you don't have a CGM, you're going to be poking your finger. Minimum of once a day before breakfast, after meals occasionally. So good blood sugar control and then good blood pressure control. It's likely you'll require one or perhaps more medications. And then at some age, probably in your 40s, a medicine to lower your cholesterol. And they're the kind of hard medical interventions, and there are the softer ones. We're big believers in a peaceful mind and mindfulness and meditation and those sorts of things. So that's what I prescribe for you.
Thanks, Dr. Elliot. Now, some of us have heard rumblings about a sanitized study in the media. Could you elaborate for us about what that's about?
Thanks, Tristan. Viewers, you've heard from me before on this. Dr. Albiani, you probably haven't. We're involved in a company, sanitize.com, who have a product that's useful for diabetic foot ulcers. It's a topical solution that releases nitric oxide that kills bugs. It's lethal to viruses, including COVID-19. And so we're involved in a collaboration with Sanitize in two areas. One, to protect frontline caregivers who are looking after people with COVID-19. So they'll not only do the usual hand washing, etc., wearing PPEs, but they'll do a daily gargle and nasal sinus washout with this solution. And then for people who've got COVID-19, they get an open label treatment the same way. Thanks, Tristan. Yeah, we're very excited about Sanitize. Viewers, if you know anybody who's got COVID-19 or caregivers of someone with COVID-19, please send them to our website, to the handout section and search on COVID.
Thanks, Dr. Elliot. The next question is from Mark. It says, at present, I'm on dorzolamide and Combigan. I feel my sight is getting worse. Any comment on why this might be, or what might stabilize my vision? Dr. Elliot?
I think that one's for me.
Dr. Albiani, I think, yes.
Yeah, so I typed in an answer. So those are medications to control pressure in the eye. They're used to treat glaucoma. And so if your vision is getting worse on those drops, it's important to see your ophthalmologist or optometrist. And number one, make sure the pressure is controlled. And also they'll do visual field testing to make sure that your visual field isn't getting worse while you're on the drops. So if your vision is getting worse on the drops, you might need more drops, or sometimes even glaucoma surgery to control pressure. But it's that's what it is. It doesn't have much to do with diabetic retinopathy or even diabetes.
Thanks, Dr. Albiani. The next question is for Dr. Elliot from James. A medication to lower cholesterol has been mentioned several times. Is there a danger with cholesterol being too low?
Thank you, James. Well, I can tell you that the cholesterol level in a newborn baby is about 0.3, which is low by adult medicine standards. We recommend an LDL level below 2. So the short answer is no, there's no such thing as a cholesterol level that is too low. We recommend a standard statin medicine. It's 1 pill a day. It costs about 40 cents. It's going to lower your cholesterol 40%. Most people start at around 2.7. So if you reduce 2.7 by 40%, you're well under 2. So most people just need a pill. Occasionally there's an expensive shot to add.
Thanks, Dr. Elliot. The next one is for Dr. Albiani from Susan. Is loss of vision from diabetic retinopathy reversible?
Yeah, so it really depends. There's different reasons to lose vision from diabetic retinopathy. So as I went through earlier, if you've lost vision because of swelling and it's been relatively recent, then that is reversible, and that's what that little graph that I showed would show you. If you've lost vision because you've got a big bleed in the vitreous jelly, then that is reversible. But if you've lost vision because of poor blood flow to your retina, sometimes that's not reversible. And so it depends on the underlying mechanism of vision loss.
Okay, the next question is from Mike. He says, I have early signs of diabetic retinopathy. My blood sugars have been mostly within range. Can its progress be slowed?
So certainly it can be slowed. And so that's where controlling your blood sugar, controlling your cholesterol, and controlling your sugar are very important. And there are very good studies to show that by controlling those, you can reduce the progression of the retinopathy or even arrest the progression.
And does smoking make diabetic retinopathy worse?
Yes, it can. So we tell everyone not to smoke. You think about diabetic retinopathy as a disease of ischemia or poor oxygenation. And so when you're smoking, you're getting worse oxygenation. So taking someone who has diabetic retinopathy and having them smoke would potentially make their oxygenation worse and worsen their retinopathy progression. Yeah.
Thank you. The next question is for Dr. Elliot from Maureen. Do you recommend going for your A1C during COVID? What about having regular eye tests? Can you elaborate?
Well, Thanks, Maureen. We recommend people do not go for their A1 testing during COVID. Now, you know, COVID's been going, what, 2.5 months now. We all kind of expect it to disappear, though people talk about the second wave. We usually say every 3 months. We're extending it to every 6 months. And as long as you watch the weekly or follow us on Facebook or go to our website, we'll give recommendations. For now, no, don't get your A1C done, but that doesn't mean you don't have to poke your finger or use your CGM. So make sure you focus on that. And then in terms of screening, I think Dr. Albiani's answered that. It's possible. If you haven't had it done forever, then it's more important than if you had it done recently.
Yeah. With the screening, and so what we're doing is if we get referrals for screening right now, even a patient that I haven't seen before, I ask them if their vision's changing. I ask them how long they've gone without an eye exam. And if they've had no vision changes, we're trying to push that visit out past the COVID crisis, really. And so it's a bit of a judgment call as we get into a safer zone in BC. You know, I think that there's only a few hundred active cases in the province right now. We're doing better than any other jurisdiction, I think, in North America. And so I think we're going to be able to get back to regular visits a little sooner than a lot of jurisdictions. But it's still better not to kind of come into a medical office if you can avoid it and have no symptoms right now, I think.
Thanks, Dr. Albiani. The next question is for you from Neville. What exactly is the field test? I'm wondering because I have one planned for next month.
Yeah, so a visual field test is a very common ophthalmology test. And what they'll do is you'll sit with your face in a little bowl and a little light will go off on the side. And the test basically measures how sensitive your visual field is in each eye independently, typically. And that can be a test of whether you have something called glaucoma. That's the most common reason to do a visual field test. And so you know, it's a common ophthalmology test, and it's non-invasive, but it is a little time consuming, and some people don't love them.
Thank you. Now, Dr. Elliot, apparently you have a question for Dr. Albiani. Go ahead.
I do, David. You know, the Minister of Health, Adrian Dix, is a BC diabetes patient. I don't know if he goes to you for diabetic eye care.
No.
It doesn't, I can't convince him to cover CGM. I presume that the VEGF therapies are covered. I know they're expensive.
Yes.
Do you have any advice for me dealing with pharmacare?
Okay. Well, so all the injections are covered in BC under a specific. It's not pharmacare actually. They're all covered under a Provincial Health Services Authority program run through Cardiac Services BC. And so there are 3 main anti-VEGF agents. 2 of them are quite expensive and 1 of them is a lot cheaper. So the 2 expensive ones are Lucentis and Eylea, and the cheaper one is called Avastin. And so, but to the patient, there's no fee in British Columbia. That program was set up in 2009. To be honest, it was a collaboration between the retina specialists in the province and the Ministry of Health. And so if any advice, I'd say like a collaborative approach where the resources managed effectively is usually something that I think the ministry is very interested in.
Thank you.
Okay, we have time for a couple more questions. This one's to Dr. Elliot from Mark. What range should I set the lower and upper blood sugar reading in my CGM when looking at TIR?
Okay, great question, Mark. So by default, we want you to set a range of 5 to 10. We all know that that sugar can go below 5 safely, though the lower it goes below 5, the more risk there is of something, of a serious problem. Now, the very fact that you're using a CGM, which has a trend arrow, which may well give you a warning, increases the safety. So I'm quite comfortable if you're doing well, you've got no history of severe lows, if you have good awareness, if you've got an alarm on your CGM, I'm happy for you to go down to 4.5 or even 4 at your low level. and then you can drop your upper level from 10 to 9 to 8, wherever you want to go. You know, I want you to have good quality of life as well. I don't want diabetes to take over your life. If you've got complications, if you're worried about your eyes or your kidneys or your nerves, topics we're going to cover in the coming weeks, then they're very good reasons to have tighter control. So yes, I'm in favor of tightening the targets as long as you do it safely.
Thank you, Dr. Elliot. Dr. Albiani, Donald is wondering, at what point of vision loss from cataracts is the decision to have cataract surgery made?
Yeah, no, that's a good question. I was just trying to type out the answer, but so cataract surgery is done when the visual symptoms for the patient are such that they're willing to undergo surgery and willing to accept the risks of the surgery. And so the risks of cataract surgery have gone down and down and down over the years as techniques have improved, the machines have improved. And so it's a very safe, very effective procedure now. And so whereas historically people would wait and wait on their cataracts and not get them done until they couldn't see at all, now you'll get patients that are younger and perhaps can't see their golf ball exactly the way they want to, asking for cataract surgery. And so it's a very safe, very effective procedure. And what most cataract surgeons will do for you is fix your prescription at the same time. So in particular, patients that are very nearsighted all of a sudden won't need glasses for distance in some instances, and they'll see better than they ever have. And so it's a bit of a moving target, but our indications for surgery continue to expand for cataract surgery.
So informative. Dr. Elliot, we're going to go to you for your outro now.
Thank you, Tristan. Dr. Albiani, a big thank you for coming on the session today, for not just teaching our clients, but for teaching me and my staff about the diabetic retina, and reassuring us that if things don't go well, that we have you and your colleagues to rely on for good outcomes. Just a reminder that next week we will discuss diabetes and cholesterol, and UBC endocrinologist and lipid expert Dr. Gordon Francis will be our guest and content expert. We apologize for not being able to answer all questions live. Any unanswered questions we will provide written answers to via email. Thank you all, and over to you, Tristan.
Thanks, Dr. Elliot. At this point, we'd like to say a special thank you to our partners, Dr. Albiani, who was a wonderful guest, and you, our beloved audience. Have a lovely end of your week and enjoy the weekend. See you next week.